My name is Vanessa Smith. I'm a physician assistant in hand surgery, and I'm going to talk about digital blocks. Not just any digital block, but how to perform the best possible digital block. Digital blocks provide excellent anesthesia for fingers, fingertip injuries where they are crushed and smushed in all the wrong places. Important to use for the patient to be able to tolerate examination and the procedure. Use caution with fingers that have tenuous vascular supply. And really important is to examine the neurovascular system of the finger and hand before you perform the block. This is not an exhaustive review of all the indications and contraindications of the use of digital anesthesia. We are assuming that you have medical background that has already equipped you to perform digital anesthesia. The goal of this talk is to update on the type of anesthetic recommended and on how to perform the procedure. There are two main topics we're going to be addressing. One is lidocaine with or without epinephrine, and where and how to inject. So the first thing I want to review is the literature regarding the use of lidocaine with epinephrine. So the first article to talk about is in 2001. Dr. Denkler wrote an article published in Journal of Plastic and Reconstructive Surgery on the use of epinephrine to use or not to use in the finger. Historically, we've been taught not to use epinephrine in the fingers, nose, penis, or toes. That's what we've all been taught. But as we can start to see in the literature, that's been disproven. In Denkler's article, he mentions the article reviewed 48 cases of digital gangrene and necrosis after local anesthesia in the digits. Much of the information is incomplete regarding the use and concentration of epinephrine, hot soaks, tourniquets, tight dressings, or pre-existing medical conditions. Only 21 of the 48 cases involved the use of epinephrine, and in only 4 of those, the concentration of epinephrine is even known. None of the cases involve xylocaine with epinephrine. There are no associations with Raynaud's phenomenon, cryoglobulinemia, or sickle cell disease. Major factors causing necrosis included the use of older anesthetics such as cocaine, eucaine, or water in 7 cases. Another review of the literature was in 2013 by Drs. Lalonde and Martin, published in JAOS. And they further note that procaine is quite acidic with a pH of 3.6, and it further acidifies to a pH as low as 1 with prolonged storage. This is likely responsible for the historical reports of finger necrosis, not the addition of epinephrine. Then in another one in 2004 in the Journal of American Academy of Dermatology also reviews the use of epinephrine and kind of revisiting that old myth. Their literature review failed to provide evidence to support the dogma that block or infiltrated anesthesia with lidocaine and epinephrine produces digital necrosis. So they are finding the same information that the other articles discussed. In 2015, Journal of Emergency Medicine also reviewed the safety of epinephrine for nerve blocks in the fingers. Dr. Ilicki published these findings and has similar findings as the other articles. This graph is from the American Family Physician Journal. And one thing I wanted to draw attention to was the use of lidocaine with epinephrine. We not only have a rapid onset, but it lasts double the length of time as lidocaine without epinephrine. This can be very helpful in the setting where you have numerous things going on and you're trying to plan. The thing we need to remember is that the antagonist is phentolamine, which is a non-selective alpha adrenoceptor antagonist. This should be available to reverse the effects of lidocaine with epinephrine. Dr. Lalonde's work has highlighted the simple and effective use of phentolamine to reverse lidocaine with epinephrine. So we've got alpha antagonist, reversal of epinephrine-induced vasospasm. You need to know where it is. In our particular clinic, it is not directly in the clinic. We need to contact the main pharmacy and the emergency room to then get us the phentolamine. This paper, published by Dr. Robert Vandermark, Corey Hewitt, and myself, highlights a specific case where a gentleman was under had surgery for tendon repair and radial digital nerve repair in zone 2 of the small finger. And after surgery, everything looked fine. He went home, but about 12 hours later, he called our office and explained that the finger was purple. And so this paper then highlights the use of phentolamine. 5 milligrams of phentolamine in 10 milliliters of normal saline was injected into the palm at the base of the finger. Perfusion improved within 20 minutes and continued to improve over the course of 24 hours. All of this evidence in my personal experience over the past 12 years of working in hand surgery, working predominantly with local anesthesia with epinephrine, demonstrate the safety and efficacy of lidocaine with epinephrine. So I want you to consider that. Here's what we use to inject. The concentration discussed in the literature and used in our office of lidocaine with epinephrine is 1 to 100,000. The safety of lido with epinephrine in the hand surgery has been well documented, and only a small amount is needed to perform a sensory block, and the epinephrine aids in vasoconstriction, so there's no need for a finger tourniquet. Using lidocaine with epinephrine will enable you to provide immediate pain relief for your patients, but also allow time for other tasks to be done before the patient is ready for the procedure. So it's something that can help clinic workflow, emergency room workflow, wherever you're working, to get somebody numb up, let them sit and let the medicine take effect while you go and do something else. Okay. We have all been taught different techniques for performing digital block with local anesthesia. Patients continue to share stories of being poked 20 times and it still wasn't numb. Or they started stitching me, but I could feel everything. Or they didn't even inject medicine, they just started stitching. A part of our oath as healthcare providers is to do no harm. We have room for improvement in this area. So these are some historical images from Green's textbook of hand surgery, of injecting directly toward the nerve, directly toward the common digital nerve, or towards the digital nerves of the finger, the ulnar and radial digital nerves, with the needle going around the finger. Here's another one. This is from the American Family Physician Journal, showing the needle going all the way through the ulnar aspect of the finger toward the neurovascular bundle. We have been taught to inject at a 45-degree angle and pass the needle lateral to the phalanx, or advance the needle until it makes contact with the bone, applying gentle pressure to the syringe plunger as the needle is withdrawn 1 to 2 millimeters. Then resistance means you have entered the flexor tenon sheath, and because the digital nerves run along the sides of the sheath, the anesthetic slowly leaks out onto both nerves. But usually what happens, no matter what we've done in the past, we have patients coming to our office that look like this as they recount the story of what happened, whether it was whatever clinic or ER they were in. They're frustrated, they have anxiety, and some of them have so much fear of needles that they are adamant that any procedure we perform, they must be under general anesthesia, because they want nothing to do with needles again. So this needs to be something that we continue to push ourselves to be better at. It's time for a change. Digital blocks can be effective and minimally painful for the patient. So that's what we want to look at next. So back to that article from JAOS in 2013, Drs. Lalonde and Martin started to show very clear graphics on where to administer the nerve blocks. Then Dr. Lalonde in 2016 outlines the simple technique. So this simple technique stands for single subcutaneous injection in the midline, proximal phalanx with lidocaine and epinephrine. Simple, right? That's the acronym, that's the concept. So he has continued to write about this, and in the book shown here, wide awake local anesthesia, no tourniquet, is the acronym used for hand surgery, where we use lidocaine with epinephrine. And because of that epinephrine allowing for vasoconstriction, we don't need a tourniquet. So Wallant is the phrase for that. You search on PubMed for Wallant and you'll find 171 results. That there's more and more coming out about the use of Wallant and more different types of procedures that can be performed in this setting with the local anesthesia. So as we start to talk about the lidocaine with epinephrine and the digital nerves for digital block, we want to review our anatomy. We want to remember that the median nerve, highlighted in yellow, not only comes up the palmar surface, but also goes to the dorsal aspect of some fingertips, of index, long, and part of ring. We've had some patients that have had an injury at the tip of index, and they told us that they were injected over and over and over on the dorsal surface of the index finger, but they were never injected on the volar surface of the finger. So we missed the nerve anatomy there completely. So here's some examples from Dr. Lalonde's book. And he has given me permission to share these with you all. So these are taken right from the book. So the idea with the simple thumb block is that you inject where the red dot is. And where the red dot is, when you inject just sub-Q, just past the skin, 2 milliliters of lidocaine with epinephrine, that will diffuse to the area that is blue. You do not move your needle. You don't skive it down or next to the phalanx towards the digital nerves with increased chance of injury to the digital nerves. You just go midline. So you're avoiding injury to the digital nerves. The medicine diffuses. And because the blue area is where the medicine is, the green area becomes numb. You can see there the green area is served by the nerve block. So this is the volar aspect of a thumb digital block. One point I want to highlight is that we don't move the needle. Like I mentioned, we keep the needle just midline. So in that regard, it's simple in its technique too. Then the dorsal thumb. So we do 1 poke volar, then 1 poke dorsal, 2 mLs right where that red dot is. The medicine gets dispersed to the area that is blue. And then because that is where the medicine is, the green area is numb. So it's 4 milliliters total, 1 poke dorsal, 1 poke volar. Here's another example with the long finger. Same concept, where that red dot is, 1 poke midline, 2 milliliters. This does also talk about sodium bicarbonate. You can definitely use that. We've found that people tolerate the 2 milliliters of lidocaine with epinephrine just fine without the sodium bicarbonate. So that's up to you, but we don't end up needing to use that in our practice. Because of where that medicine is in the blue area, that whole green area is numb. So this is the beautiful part of this technique, that it's simple for us to perform and it's effective. Here we are on the dorsal side of, oops, sorry about that. On the dorsal side of the long finger, 2 mLs in the area. We've got the blue where the medicine will diffuse to, and then the green becomes numb. The key with this is to allow 20 minutes at least for the medicine to set up, for the medicine to take effect. We've got to give it time. I've been in the dermatology office enough times where they poke that lidocaine in and they start cutting and I can feel everything. So we've got to give it time, give the medicine time to work. Okay, so here's an example. We've got the volar surface of the long finger being cleansed. We've got ethyl chloride that we use to spray the surface. He's also creating noise for the nerves by pinching the volar aspect of the wrist. And now we're going midline of the proximal phalanx. Needle is not moving, it's sub-Q, and 2 mLs of lidocaine with epinephrine is being injected. Then dorsally, we're cleaning the surface over the proximal phalanx. Some ethyl chloride spray again to cause a little distraction for the nerves, make it cold. He's pinching the skin on the dorsal wrist. Again, we're creating noise for the nerves. There are a lot of nerve endings in the hand, so it can be pretty painful. So as much as we can confuse the nerves as to what's going on, the less painful the patient will feel from the poke. So that is it. And that is simple, right? That's just dorsal and volar. There's no further poking. And this is the idea is for a crush injury, right? We see a healthy hand here, but the idea is for a crush injury. We don't have to go poking in the wound. If we're proximal to the wound, about the proximal phalanx, we're giving good anesthesia for the end of the finger. So it's simple. It's a simple technique. It's effective. It's less painful for the patient. We need to know the digital nerve anatomy. We need to allow at least 20 minutes for the anesthetic to work. And you must use local anesthesia after you perform your physical exam. We want to know how the nerves are working, how the neurovascular bundle, the digital arteries and veins are working. But we want to use it before we do any procedure, before we wash out the injury or perform an IND or do any suturing. We must use local anesthesia for digital block. Here are the references. And that wraps up the talk on digital blocks. I hope you've enjoyed this. Thanks for watching OrthoRefresh.com.